Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. Today we'll be talking on very one short topic, very frequently asked as a short note. Maybe asked in oral also. And once in a while you will see those patients in your everyday practice. That is trigeminal neuralgia. Meaning is very simple. Neuralgia means pain because of nerve. And trigeminal nerve, that's why it is trigeminal neuralgia. The other name for that was Douloureux. So this was the two name for the painful on a face due to trigeminal nerve involvement, and that was labeled as trigeminal neuralgia. Douloureux. Also it was called as a trifacial neuralgia, Fothergill's neuralgia, prolepsia, neuralgia epileptiforme, and that was also labeled as suicidal disease because good number of people who were not able to tolerate that pain used to commit suicide. So trigeminal neuralgia is sudden, unusually unilateral, severe, short lasting or we call brief, stabbing type or lancinating type, recurring pain in the distribution of one or more branches of fifth cranial nerve, that is trigeminal nerve. So trigeminal neuralgia was also called as prosopalgia or Fothergill's disease, is a neuropathic disorder characterized by episode of intense pain in the face originating from trigeminal nerve. It was also described as chronic neurofacial pain disorder due to trigeminal nerve, and it is extremely painful. These two people, well-known people, they were suffering from trigeminal neuralgia. Yes, Salman Khan, Chris Gale. And it will be in a distribution of the branches of trigeminal nerve, maybe ophthalmic division, maxillary division, or mandibular division. We call V1, V2, V3, any one of those, or it may be in all the three areas. So trigeminal neuralgia is also called tic douloureux. It is a neurological condition involving recurrent episode of facial pain in the distribution of trigeminal nerve. The estimated percentage is 4 to 13% per 1 lakh population each year. Lifetime prevalence is estimated to be between 0.16 to 0.3. So very few people will have a lifetime pain in the facial region due to trigeminal neuralgia. It is more common after the age of 50 and higher likelihood of having trigeminal neuralgia is in those with multiple sclerosis. So one of the common etiology is multiple sclerosis. We usually classify into two big groups. We call classical and symptomatic. Some people divide into three stages like pre-trigeminal neuralgia, idiopathic trigeminal neuralgia, and symptomatic neuralgia. So these are the three different groups you divide: pre-trigeminal, idiopathic, and symptomatic. Symptomatic is by and large called secondary, and idiopathic is usually called classical. So idiopathic, primary, typical, classical, or type 1. These are the same name for same person, that is idiopathic. Sorry, here I is missing. Primary, typical, classical or type 1. And symptomatic is labeled as secondary, symptomatic, atypical or type 2. By and large, we remember idiopathic, or we call primary and secondary, typical and atypical, classical and symptomatic, type 1 and type 2. These are the common terms which are being utilized. Also, there are other names given to that. Normally, we use two common names, typical and atypical. Second is multiple sclerosis related trigeminal neuralgia, failed trigeminal neuralgia, secondary, post-traumatic, and pre-trigeminal neuralgia. Etiology wise, we divide into idiopathic and secondary. So, idiopathic, very frequently, it is because of neurovascular compression. And again, in that neurovascular compression, it is very frequently because of some anomaly in an artery. But secondary is very frequently because of demyelination of the nerve. The another disorders which is very common is multiple sclerosis or compression by bony part, that is petrous ridge, or post-traumatic or tumor, intracranial vascular abnormality, and another very common is post-herpetic neuralgia. So these are the common etiology for trigeminal neuralgia. We usually say nerve compression, space occupying lesion, and multiple sclerosis comes topmost on the list. So factors which are responsible for trigeminal neuralgia is demyelination, genetic tendency, or some kind of trauma, or tumor, or multiple sclerosis, or there is some immunological factor, or there is a compression, or due to stress, etc. All these factors play a role, out of which multiple sclerosis, compression either by tumor or by artery or by a bony prominence, maybe occasionally immunological mediated, etc., becomes the factor responsible for trigeminal neuralgia. We already mentioned you can divide into two big groups, intracranial and extracranial. Extracranial will be vascular factor, dental, post-traumatic, infection and viral etiology. And among viral, post-herpetic. While intracranial, very commonly because of bony process like petrous ridge compression, maybe by internal carotid artery pulsation, multiple sclerosis, tumors at CP angle tumors we call, or maybe because of basilar artery aneurysms or superior cerebellar artery abnormality, we call vascular abnormality. 3 to 5% in 1 lakh, age more common, more after 50 years. Prevalence is approximately 1.5 per 10,000, with incidence approximately to 15,000 cases per year. Multiple sclerosis is found to be a risk factor. In some, even hypertension is believed to be one of the risk factor. And very rarely you will get in a very young person. So that will be the most common. By and large, female to male ratio is 1:6. Age of onset we already mentioned, 90% of time more than 50 years. V3, that is mandibular, is more common than maxillary, than ophthalmic division. Ophthalmic division is less than 5%. In only 10%, all the three divisions may be involved. And bilateral is very rare, occasionally in 5% of the group. Trigger zones are very common in 90% of the people. You might come across the refractory person also. Spontaneous remission may be seen in 50% in less than 6 months. That way, and you can come across a group of people we call pre-trigeminal neuralgia. As far as pathophysiology, we know that there are three divisions of trigeminal nerve, that is ophthalmic, maxillary and mandibular. We call V1, V2 and V3. Trigeminal nerve is responsible for sensation of the face and motor movement, that is for muscle of mastication. Almost idiopathic is in a good number of people, but in 80 to 90% of the time it is because of compression of the trigeminal nerve, and compression is very frequently by an artery, maybe a normal artery or maybe a abnormal artery. The common artery involve a superior cerebellar, anterior inferior cerebellar artery, or maybe vertebral artery, and very rare because of petrosal vein. Tumor may also lead to like CP angle tumor, and demyelination is a very common, which is following a compression by either an artery or by bony structure, and once in a while following an infection like herpes zoster. So atherosclerotic blood vessel will press on the root of the trigeminal nerve. So because of constant pressure, you will have a focal demyelination, hyperexcitability, and episodes of intense pain. This is the basic pathophysiology which is being seen. So chronic irritation, focal demyelination, ectopic action potential, decrease in segmental inhibition will lead to paroxysmal discharge of interneurons of nucleus, and that will give rise to trigeminal neuralgia. We usually come across two big groups, classical and symptomatic. Neuralgia is a severe headache which is knife-like, sudden onset, paroxysmal, sharp pain, which is usually described as electrifying pain. Location of the pain is along the branch of the trigeminal nerve, and the most common branch is mandibular, second common is maxillary. The pain will be lasting for a short period and maybe 5 to 10 times per day. Pain is very frequently triggered by chewing, brushing, etc., or even while during shaving, also washing face. More common in women and above the age of 50. Milder form can be atypical trigeminal neuralgia, or we call symptomatic variety. Symptomatic variety. So there is pre-trigeminal neuralgia, usually will be coming with dull aching pain. Usually it will start before getting an sharp electrifying pain. This is called pre-trigeminal neuralgia, and then it will end into classical trigeminal neuralgia. Idiopathic neuralgia, where etiology is not known, while symptomatic is where we know the etiology. And in between the two episodes, we might have symptom signs of the basic etiology. So this is a description of a trigeminal neuralgia, pain characteristics, attacks, trigger zones, no neurological deficits, and how you come to the diagnosis. Just in one slide only everything is mentioned. You can utilize for a short note, but we'll be going through the second slide now. So classical pain, sudden onset, intense pain, excruciating pain, almost most common unilateral, aching and burning prior to the attack we call as a pre-trigeminal neuralgia, and then person gets a shooting pain, jabbing pain or electrifying pain, recurrent episode, frequency will increase over a period of time, duration of the pain is right from few seconds to a minutes, very rarely for hours to days, very rare, not very common. Usually it is for few minutes to hours. Mandibular region is most commonly affected, followed by maxillary and then ophthalmic. Triggering factor is movement of the muscle of the face like eating, talking, touching, while doing brushing, shaving, washing face, etc. And you might have a facial spasm during that episodes. Diagnostic criteria for classical trigeminal neuralgia is paroxysmal attack of pain lasting for few seconds to a minutes, and it is affecting one division or more than one division, very occasionally, maybe in all the three divisions. The pain is intense, sharp, superficial, stabbing type and triggered by triggering factor or by triggered areas. Attacks are similar in the individual patients. There is no neurological deficit during the episode or after the episode, and it is not attributed to any other cause of facial pain. These are considered as diagnostic criteria for classical trigeminal neuralgia. So usually classical or idiopathic trigeminal neuralgia duration is almost less than 2 minutes, usually affects one division or two division, occasionally only three divisions, sudden onset, always unilateral, severe sharp stabbing pain, electrifying pain, precipitated from trigger area. Patient is pain-free between the two paroxysms, no neurological deficit, no causative lesion or no causative findings, and it is more than 40 years age. So after a good investigation, still we are not able to find out the etiology. We'll put them into classical or idiopathic or type 1. While symptomatic pain is as identical like classical, it is persistent pain, and sometimes person will have some symptoms and signs between the paroxysm. Good number of time they will have a sensory impairment and may or may not be associated with neurological deficit. And you will be able to confirm the diagnosis of etiology by either investigations, mainly by CT or MRI, or maybe even after angio. Good number of time it is bilateral and it may be also seen in younger individuals, and that we label as symptomatic. So classical variety and atypical variety, or the typical and atypical. Indirectly we call atypical as symptomatic. Trigeminal neuralgia prevalence is this is rare, while this is atypical. Facial pain is quite common. This may be in a trigeminal area, while you might have atypical facial pain in face, neck or ear, because the etiology will be ear problem like otitis externa or otitis interna or media. Neck pain may be because of cervical spine or maybe musculoskeletal pains. Classical trigeminal neuralgia will be lasting for 2 minutes, while this will be for hours and days. This is like stabbing pain, electrical pain, etc. While this will be dull aching pain to a throbbing type of pain. Intensity is very severe in trigeminal, while this is mild to moderate. Provocating factor like touch, washing face, shaving, eating, talking, etc. may precipitate trigeminal neuralgia, and associated symptoms are nil. While here, atypical facial pain very frequently provoked by stress or maybe by exposure to cold, and you will have invariably some sensory symptoms and signs may be seen. If you look at this picture, this is one picture which gives you an entire idea regarding the full lecture. That is, the person will have typical pain like shooting pain, terrifying, exhausting pain or unbearable pain, character wise. Severity wise, moderate to severe, but good number of time it is very severe. Sight wise, maxillary division is most common. It is unilateral, and it is very common in mandibular division, more common than maxillary and ophthalmic division. Right side is more commonly involved. Almost 60% of the time it is on the right side than left side. So this is as far as distribution is concerned. Now if you go to the associated symptoms or triggering factor, may be triggered by trigger points, and maybe sensory changes may be seen sometime, particularly in a secondary variety. As far as duration is concerned, attack will be lasting for seconds to a minutes. In secondary, it will be a dull aching pain. Complete remission may be there in few weeks to a month. Provoking factor are usually light touch, or maybe by eating, talking or washing of the face or brushing, etc. Sometimes it may be spontaneous. It is relieved by drugs or sometimes by sleep. This is a typical description of a classical trigeminal neuralgia. So these are provoked by touching the face in a particular site we call as a trigger zones, like chewing, speaking, brushing, shaving, washing of the face, or even by stroking your face while shaving, eating, drinking, talking, putting on a makeup, encounter even with a breeze or even while smiling also. So this may be all different types of triggering factors or provoking factors. And characteristic of the disorder is being that the attack do not occur during sleep. Good number of times this do not occur during sleep. We already mentioned regarding the incidence, it is almost 4 to 5 in 1 lakh. Mainly after age of 40 to 50. Female are more common than male. In 60% of the time on the right side, only in 3% bilateral. Mandibular is most commonly involved. Second common is maxillary. Here they have mentioned maxillary is more common. Ophthalmic is very, very rare. So V3 is more common than V2 than V1. And in all the three division, it is only 1%. There are some red flag signs because if you go get those signs, always suspect secondary. If there is any residual neurological finding like sensory finding or motor deficits, or person has got oral, dental or ear examination, some abnormality like dental abscess, or person has got ear discharge, otitis media, or person has got some oral findings, etc. Do suspect and try to rule out other etiology. If it comes at the age less than 40, it is bilateral to start with. Person is having associated symptoms like dizziness, vertigo, vomiting, and other neurological findings. Always consider that as a red flag. Hearing loss, numbness, pain lasting for a very long period. Pain is also outside the trigeminal distribution, or if a person has got visual changes, etc., will suggest some other secondary etiology. By and large, the progression over a period of time, if you see here, this is a period of exacerbation, period of remission. So remissions are more in an early stage, then slowly the period of exacerbation increases, and later in the disease course, almost the period of remission disappears. But in few number of people, there is a very good remission in a short period within few weeks to a months. As far as investigation is concerned, only in the person in whom you are suspecting secondary, a person who has got a red flag sign will require an investigation like MRI or CT scan, or may require a diagnostic nerve block to find out the possible etiology. By and large, good examination, good history, physical examination and neurological examination will be enough. And in a suspected case with a red flag sign or with a secondary variety of or type 2 variety of trigeminal neuralgia, you will go for MRI or CT, or you can go with MRI angio or CT angio. Look for auditory nerve because CP angle tumor will be quite common etiology for trigeminal pain. Evoke potential can be done, and you must also go for cardiac workup because hypertension can be also one of the factor which can increase. So try to rule out by clinical, symptomatic, or you can refer to a specialist. As far as the treatment part is concerned, one is symptomatic, mainly analgesics, and you can use a drug which decreases the nerve irritability like pregabalin, gabapentin, etc. When you don't get relief by analgesics and by the drugs, local Injections by sclerosing agents like alcohol, we call ablation. But while doing that, there is always a one chance that you will be damaging the other function of the fifth cranial nerve. Maybe you may damage the motor fibers. Hence, now stereotactic surgery has come up. So there are two basic treatment, medical treatment done by the drugs, and in surgical treatment, that is stereotactic surgery has been now replacing the local sclerosing agents. But in some of the condition where particularly you can identify the compressive symptoms, decompression or lifting up the artery which is compressing the nerve can be done, and by putting a patch in between the artery and the nerve. This is a very good treatment. So treatment can be pharmacological, and you can use carbamazepine, phenytoin or gabapentin. The first line is carbamazepine and oxcarbamazepine. In surgical, non-destructive is microvascular decompression, and among the destructive, we call ablation of the nerve by glycerol or by alcohol, balloon decompression, and radiofrequency thermocoagulation, we call rhizotomy, can be utilized. And this will destroy the nerve, but one drawback of that, you will have a damage to other fibers also, which will produce residual neurological deficits. So in surgical treatment, peripheral injection, peripheral neurectomy, cryotherapy, peripheral radiofrequency, neurolysis by thermocoagulation, and glycerin ganglia procedures can be done. You can pass like this and inject, or you can go for all these different types of therapy. So right from microvascular decompression, percutaneous ablative procedures by radiofrequency, gangliolysis, glycerol, rhizolysis, balloon compression, stereotactic radiosurgery, that is by gamma knife or by linac based, or you can go for peripheral ablative procedure either of V1 and V2 pain, peripheral branches, neuronectomy or alcohol neurolysis, or you can go for a destructive procedures like partial sensory rhizotomy or subtemporal gangliotomy. These are many different procedures which can be there. But while doing this destructive procedure, there is always a chance of residual neurological damage. As well as in this also, there is a chance of residual neurological damage. If possible, determine the cause lesion and treat the basic etiology. Among pharmacological treatment, anti-epileptic drugs, muscle relaxant, tranquilizers, etc. Some person also tries stents, that is we call physiotherapy, can be done. And we already mentioned among the different types of inhalers they try, topical applications, drops, and we have already mentioned anti-inflammatory drugs and anti-epileptic drugs, particularly oxcarbamazepine and carbamazepine. There are alternative methods like acupuncture, Ayurvedic medicine, botulism, Botox injection, cervical chiropractic, exercise, homeopathy medicines, cold compression, hypnosis, low intensity laser, lidocaine creams and patch, myotherapy, osteopathy, TENS, vitamin B12, yoga, biofeed, and many more. But these are not 100% effective. So among the algorithm, we already mentioned that if you find a trigeminal pathology, that is symptomatic trigeminal neuralgia, then you treat the underlying cause. And you can use medical treatment like gabapentin and other drugs. And if it is a classical variety, we are not able to find out the etiology, then you can go for first line is always oxcarbamazepine and carbamazepine. And then you can switch over to other group of drugs like lamotrigine, and if still not effective, even you can use baclofen, and you can go for different surgical, non-destructive and destructive procedures. So this is a medical therapy, this is non-destructive procedures, and there are destructive procedures. You can go for those. As far as complication is concerned, mainly because of a person who does not get relief, he will have a psychological problem, maybe anxiety, maybe depression. If it is secondary, you can have complication due to basic etiology. And if a person undergoes surgical treatment, post-residual neurological deficit is very, very common. And when the drug has to be given in a little full therapeutic doses, the chances of side effects because of drugs, pharmacotherapy will be high. So these are the complications. So I end my lecture here. This will be very frequently asked as a short note, very commonly asked in your oral. Also, you will come across in your everyday practice. So again, thank you very much for taking out time. I know that your time is very valuable and I do appreciate that you have spent some of the time with me. If you like this particular lecture, please don't forget to press button like. Don't forget to subscribe and press bell icon. And if you feel that this is beneficial to your friends, you can share with your friends also.